All right, we can get started here. So welcome everybody to the first grand rounds of 2023. We're very excited today to be hosting Dr. Raquel Bennett. She's a psychologist and ketamine specialist from Berkeley, California. She is fascinated by the antidepressant and anti-obsessional properties of ketamine and has been studying them since 2002. She also has a long-standing interest in the psychedelic and mystical properties of ketamine and the potential for this medicine to be used for spiritual exploration. Dr. Bennett is the founder of Kriya Institute and Kriya Conference, which are both devoted to the use of ketamine in psychiatry and psychotherapy. She's given hundreds of lectures and trained thousands of clinicians worldwide on the safe and legal use of ketamine in clinical practice. You can learn more about her work at www.kriyainstitute.com. I'll also add that Dr. Bennett is very generous with her time, educating countless providers on the use of ketamine for more than a decade, including a wonderful presentation to our UCLA Psychedelic Psychiatry Interest Group last year. It's an honor to introduce her today and look forward to her presentation. I'll turn it over to you, Dr. Bennett.
Oh, thank you so much, Dr. Price. It's an honor and a pleasure to be here today. Let's go ahead and get started. And of course, I want to thank you and Dr. Heltz for hosting this event and making it happen. So we've already talked a little bit about me. I wanted to just make sure that I point out that I work with a team of medical professionals in order to make this work possible. And I've been doing this for 20 years. I just celebrated my 20th anniversary of my obsession with therapeutic ketamine. I have no disclosures or conflicts of any kind to report. So here's what I think I'm going to be talking about today. There's a lot of material to cover. I'm going to start with a conceptual talk about different approaches to working with ketamine in clinical practice. That is really the foundation of understanding what's happening in the field and reading and analyzing the research literature that's coming out. So I'm going to start there. And then if there's time, I'm planning to talk about the clinical indications for legal ketamine treatment according to the literature, and then we'll end with Q&A facilitated by Dr. Price. I wanted to make sure that I said that I'm talking today about the use of generic or racemic ketamine, and that this is currently an off-label indication, not approved by the FDA for a mental health indication. It is approved for anesthesia. But it is in DEA Schedule 3. We can come back to that. I also wanted to say, by way of introduction, that there is an important, essential relationship between what we can see in the field, observations from the field, and formal and controlled academic research. That there's a circular and symbiotic relationship between these different ways of knowing, and that they inform each other. So today I'm going to be trying to combine information from the field with information from research studies together in this talk. So you probably know this already, but let me just briefly review. Ketamine developed in the 60s for surgical anesthesia, has rapid acting antidepressants and anti-obsessional properties. It has prominent dissociative or hallucinogenic properties in a particular dose range. We're going to talk about that. And it's dirt cheap. We're going to talk about that tool, and talk about that too. And it's a flexible tool that can be used in a variety of ways. Dirt cheap. That was the point I wanted to get across here. So in clinical ketamine treatment in the office, there are 5 variables that the clinician can control or adjust. So it's critical to understand these. And so the variables are the things that you can modify to meet the patient's needs are the following. The variables include the route of the route of administration. In other words, how are you choosing to put ketamine into the patient's body? A lot of options for that. How much are you giving it at any given time? In other words, what's the dose? The frequency, how often are you doing this? The setting, the physical setting, the surroundings. Turns out that this is a critical variable for visionary medicines like ketamine, one that's often underestimated. but a really important one. And finally, the relational context, sometimes called the clinical presence at the time of administration. So ketamine is an experiential medicine, meaning that the experience of receiving it is every bit as important, maybe even more important, than what's happening at a biochemical level. And I know that's kind of a new idea, but it's true. And one thing that we need to be thinking about as we evaluate these different paradigms of treatment, it's important to look at the person who's providing the ketamine. How do they understand their job? What is it that they think that they're supposed to be doing while ketamine is being administered? Some options for that include medical monitoring, or an emphasis on medical monitoring, using technology to track the patient's vital signs, etc. Other clinicians are psychotherapists and are in relationship with their patients in a therapeutic relationship and have the skills and permission to explore tender psychological terrain. Other clinicians imagine themselves as a psychedelic sitter or guide, someone who is radiating warmth and being an unobtrusive witness in the room to provide support, but not really psychotherapy. And these are critical distinctions in how these services are provided and are probably important in understanding the different clinical outcomes. I want to say something more here about the different routes of administration. A lot of people don't know this, but there's lots of different possible ways to get ketamine into the patient's body. And two of them, infusion or intramuscular injection, have very high bioavailability. They're highly precise and efficient. Bioavailability for IV is thought to be 97%. Bioavailability for injection is thought to be 93, 94%. So easily over 90%. 90% of the medicine or more makes it to the target organ, in this case, the brain, to do the job that it was intended to do. Here's the problem. All the other routes of administration, their bioavailability drops precipitously to under 50%. So nasal spray, estimated at like 40%, but it varies. These transbuccal lozenges, troches, they vary in their absorption and bioavailability, estimated at 40%, but in reality could be anywhere between 20 and 60%, etc. The other forms are not used that much in psychiatry. And I want to say that this variability and lack of efficiency is highly undesirable for clinical treatment because it lacks precision. So I wanted to make sure that you knew that. Also, when you're converting from one route to another with a patient, it's important to do the math and account for the changes in bioavailability. Okay, moving on. So now that we've looked at the variables, I want to present and discuss a couple of different approaches to working with ketamine. So 3 different approaches to talk about. The first one is the biochemical approach. In the biochemical approach, here we're looking at what the medicine is doing on a physical or biological or biochemical level, just the medicine alone. And the hallmark of this approach is the absence of other mental health services or psychological support, the lack of those things. So interestingly, most of the research that was done, certainly pre-2018, I'd say 80% of the existing published research utilized this approach. Let me tell you more about it. I'm going to start with the research protocol, which is 0.5 milligrams per kilogram of ketamine given by infusion over 40 minutes. The researchers who developed this protocol thought that psychedelic experience or the psychedelic properties of ketamine were inherently a bad thing, that they were a problematic side effect that were termed in the literature as psychotomimetic, meaning mimicking psychosis when the patients reported any kind of unusual experience or sense of opening. And this is a huge mistake. It's not psychosis inducing. This is a misunderstanding of psychedelic experience. But in any case, I say that because the early researchers deliberately designed this protocol to dose below the psychedelic threshold, essentially. That's how they came up with this number. Problem, the result is not particularly robust. It does work for some patients, for sure, but for the majority of patients, this dose is too low. And to get around this problem, and if you don't want to increase the dose for some reason, to get around this problem, the next wave of researchers came up with the idea of doing a cumulative series of ketamine treatment. So doing 6 ketamine infusions in a short period of time, usually done in 2 or 3 weeks, as a way of cumulatively getting enough ketamine into the patient's body to do the magic thing that ketamine does for depression, but attempting to avoid psychedelic experience in any individual sitting or session. Let me say more about this. So again, here there's no psychotherapy that is required or recommended typically. Certainly it was not in the early research. Psychedelic properties are minimized or avoided. And so this is inherently a surgical or a medication model where where all of the healing effect, all of the improvement is attributed to what's happening at the level of the neuron or the cell receptor or whatever. And that it certainly has value. There's no doubt that it works. It works some of the time. But there's 2 challenges with this approach, two issues, 2 limitations that we have to talk about. First of all, the beneficial effect of ketamine is temporary. It's actually quite short-lasting. It should last between 3 and 14 days, on average about a week. And then it wears off, and then what are you going to do? So that's the first thing. And the second thing is that you're forcing the patient into a passive position, or you're casting them in a passive role. What do I mean by that? I mean that the patient isn't called upon to engage in their own treatment, to do anything other than to show up for the appointment and then passively be the vessel that receives the medicine. So while this passive approach is a perfectly good model in medicine for a surgery where the patient lies there quietly, or for something like chemotherapy where you just need to get the medicine into your body, okay, those are valid applications of that approach. But the question that I have is that the best use? Is that the best way to help somebody who's having a chronic mental health problem? Or is it better to empower them to participate more actively in their own treatment and wellness? And so that's the question that I want you to contemplate. That said, I like to be fair and present both the pros and the cons, or the different ways of using something, looking at it in a balanced way. I would say that this is for sure the way to go for patients who have physical pain as their chief complaint, or for patients who are medically complicated in any way and need to be seen at a higher level of care and monitoring. So that's what I have to say about that. Let me give you a couple of examples so that you can visualize it, of how this approach is used. So if the patient is given an infusion in a research study, or the patient is given an infusion in an outpatient clinical practice, that would be an example of this approach to ketamine treatment. Similarly, S-ketamine, the nasal spray, was modeled after this infusion, the research done with the infusion. So it's a similar approach with an emphasis on the biochemical effect and not requiring any supportive psychological services. Similarly, when physicians send low dose sub-psychedelic compounded products for the patient to use at home, again, we're still in this biological biochemical model that's emphasizing what's happening at the chemical level. And I would be remiss if I didn't say something about the S-ketamine product. A couple things to note. First of all, it's vastly more expensive than generic racemic ketamine. In fact, so generic ketamine, 100 mgs, that's a substantial dose, costs about $1.59 as a medical supply currently. The equivalent dose costs $850. One would think that maybe this enantiomer works better somehow clinically, has different clinical results than the generic, but that in fact is not true. In a head-to-head comparison, it was found that a generic ketamine was slightly more clinically effective. So that's concerning. This could easily be a whole nother talk unto itself, but just wanted to bring your attention to that. And here are some references. These are also available. Ava, if possible, can you put the reading list in the chat? For your convenience, I have a reading list online. You can find these articles there, but here are some references to support what I've just shared. As I said, you can access them on the reading list online. Okay, moving on. Same medicine, different approach. Let's talk about a different way of using this tool. So here I want to talk about ketamine-assisted psychotherapy or ketamine-facilitated psychotherapy, or using ketamine embedded in a psychotherapeutic approach. So the hallmark of this is using ketamine in the context of an ongoing psychotherapy relationship and using the ketamine as a catalyst or potentially a lubricant for the psychotherapy dialogue and for the emotional work that needs to be done. So this is a profoundly different paradigm, profoundly different approach, using the same medicine, but a completely different way of thinking about how to use this tool. Let me give you some more details about that. Historically, it was done with injection. It could also be done with lozenges. I have to say, honestly, that I'm not a big fan of lozenges because of this tremendous variability and lack of precision in dosing. You can't get around that. But sometimes that's what's available, and so that's sometimes what people are using. And again, it's still low dose. It's still sub-psychedelic in dose. You don't want the patient to be too medicated. That's a different paradigm, too far out there, because then they are not able to engage in dialogue or self-reflection in a meaningful way. So again, this is still a low dose strategy, lower dose. Here, we're spreading the frequency out. Instead of doing it every few days, we're letting weeks pass in between these ketamine-facilitated therapy sessions because people need time to process the material that has arisen. Side note, I'm aware that some clinicians do this once a week for a time-limited series, and that's okay, but you wouldn't want to do that ongoing. And so here, again, the emphasis is on the psychotherapy relationship, usually done in a double session. And so this is fundamentally a psychological and relational model where as I said, the therapy is central and essential, still in a sub-psychedelic dose. This is ideally suited to patients who are able to make use of psychotherapy. Not every patient enjoys talking about themselves, so they shouldn't be forced. But the challenge here is that the therapy is expensive currently, and it's time consuming. It takes a while to make progress. And so that's the bottleneck in providing this service, is making the service more broadly available and helping it to be subsidized or more accessible from a cost perspective. That's a bigger and systemic problem. But while we're here, I want to make sure that we note that there is a significant difference, I think, between two things that are often mixed together, but let's parse them out. There's a difference between using an occasional ketamine session in the context of an ongoing psychotherapy relationship, where the patient and the provider know each other quite well, and where there's a lot of not only familiarity, but trust in that relationship. That's one thing. That's true ketamine facilitated psychotherapy with occasional ketamine use. And that is not the same thing as when people show up and they meet with a therapist that they don't know, and they want ketamine in the presence of a therapist, but whether it's not actually a therapy relationship, or where they're not well known to each other. These are two different things that I said are often mushed together, but that we need to be talking about separately, because I think what we're observing is that there's a difference in outcome. Let me take a sip of water. We just need better language to be more clear and specific. I want to say here that the role of the therapist, there's a couple of things that the therapist is doing, or that the therapy is providing. Obviously, the therapist is available to help unpack psychological material as it emerges. In the event that there's difficult psychological experience, that definitely happens. Patients can be accidentally triggered into revisiting traumatic material. And so having a skilled support there to assist with that is valuable. But the thing that we're not talking about enough is the importance of acquiring new skills, often done through psychotherapy, or it could also be done with a book or a mentor. But the thing is that we don't want to create addiction. It's not a good idea to have patients become dependent on ketamine in order to feel okay, but rather they need to deal with their difficulties on the inside, or acquire and practice new emotional regulation skills or social skills, or what's needed, so they can do the most that they can on their own to move themselves toward wellness and to stay there. So I just wanted to clarify why this is important. That's a picture, by the way, of dendritic sprouting from a research article representing the neuroplastic window, by the way, that occurs following ketamine administration. Don't have time to get into that right this second. Anyway, here's some citations to support what I'm saying, and so that you can read more about it, just there for your enjoyment. And you can also go back to the reading list to find these articles. There's a lot of articles. I just picked out a few of my favorites, just trying to prioritize what I think is good as a starting place. Okay, let's move on. So a different way of using ketamine is to use it to invite or induce profound psychedelic and mystical experience on purpose. This is sometimes called the ketamine journey. And you would only do this when a couple of criteria are met. The criteria are, number one, that you as a clinician or provider have skills and training in doing this, because this can get tricky. So you need special training, number one. And number two, you would only do this if you've determined that the patient is truly a good candidate for this. And not every patient is. Not every patient is a good candidate for this at the beginning of their ketamine treatment. Some are never a good candidate for this. And you need to take a full training in order to be able to parse that out. But just to say, both the clinician and the patient need to be ready. So this is typically done with injection. It's possible to do with lozenges, but again, I wouldn't recommend that. And so the psychedelic range, or the point at which the medicine becomes more fully dissociative, seems to start around 1.0 milligrams per kilogram. In our clinical practice, we've been doing this for 20 years. I've been studying this for 20 years, rather. 1.5 mg/kg. We don't go higher than that in an outpatient setting. I think it becomes more amnestic and more disjointed when you go higher. Some patients get higher than that in an anesthesia setting, but we don't do that in a psychiatry or psychotherapy practice. And I've observed that there appears to be a sweet spot for treating refractory depression around 1.25 mg/kg. That has not been formally studied. That's just an observation from the field. In fact, it's bimodal. Some patients actually respond well lower. There's like can't think of the word I want, but a high point in the curve, and then there's another peak in the curve at around what appears to be about 1.25 mg/kg. Here's the thing, you don't want to do this frequently. Now we're on the scale of months. Once a month might be okay. Once a quarter seems about right. You need time with the patient to prepare them for this experience and then to make use of the material that emerged. And so one of the problems that we're seeing in the field are these mail order these mail order companies that are selling psychedelic experience for the patient to have once a week or multiple times a week. That makes no sense to my brain and is clearly not supported by the existing research literature. So I wanted to point that out. Anyway, the patient's experience, they're essentially partially and temporarily paralyzed at this dose. It's a dissociative anesthetic. They're in a state of full dissociation, usually. In other words, they're not getting a lot of signals from their sensory organs. Temporarily, that lasts about an hour 15. And so during that period, they are typically experiencing colorful, dreamlike visuals or visions. So that gives you a sense of it. And it takes about a half a day to do this. When we do group work, we keep people with us basically all day. But you get the idea. There's the info for you. So this is inherently a psychedelic or shamanic model. And that means that the visions are thought to be valuable, potentially valuable. And so the emphasis here is on creating or inviting these psychedelic visions. And as I said, this is not appropriate for every patient. A lot of people are not a good candidate for this. And I wanted to clarify that there's typically not talk therapy during the active phase of medicine, but the therapist's presence is important. And the main thrust of the therapy, or the main bulk of it, is happening before and following the active medicine. I just wanted to be clear about that. So here, instead of avoiding the psychedelic properties of ketamine, here the psychedelic properties are the essence of this kind of experience. So this would be well suited for people who know how to observe their own minds. Some people come to that through meditation or psychoanalysis. They may have explored their minds with other substances. And so again, so you want to make sure that you're choosing people well. But as I said, this is not appropriate for many clients. And certainly I would be aware of clients who are seeking a magic bullet or are in the current zeitgeist is idealizing psychedelic experience. So people who come and want to be fixed quickly, but who don't realize that this is really opening the door to a lot of psychological work. You want to be cautious about that. There's a hidden assumption here, by the way, and the hidden assumption in how psychedelics have been used up until very recently, I think, but that traditionally psychedelics are used in community or in relationship. And the relationship between the journeyer and the people supporting them is really important to create a space that feels emotionally safe. And I just want to say that it's not just about the dose, but rather about the context is essential in understanding how to use all these psychedelic tools and in getting good outcomes with ketamine. Say more about that in a minute. So, as I said, I've been doing this a long time, and I've noticed that there are certain clusters of themes that tend to emerge in patients' psychedelic ketamine treatment. As I said, we're mostly treating them for refractory depressive disorders or other psychiatric concerns. And so here are some of the themes that come up pretty commonly. I don't know why so many people describe space travel, but it's certainly interesting. And people talk a lot about the sacredness of their own life. I don't know why or how ketamine is doing that. Nobody knows, but it is notable that it comes up so frequently. So here's a little bit about what that looks like. I also wanted to point out that the key thing that distinguishes therapeutic ketamine use from recreational ketamine use is identifying and implementing an actionable step. So an actionable step, there may be more than one. An actionable step is information from the journey that informs the patient of something or some things that they can do in their regular, everyday, non-medicated life to move themselves toward wellness. And so the therapy that surrounds psychedelic experience, part of it is to help the patient identify these actionable steps and then to support them in manifesting it behaviorally. Again, this could be a whole talk unto itself, but you get the idea. This is really a key concept. So here, I touched a moment ago on mail order ketamine. I want to come back to it. I would be remiss if I didn't mention this. A new development is that it is possible to buy psychedelic experience online and have medication mailed to the patient, but without any clinical oversight, essentially. This is a terrible idea. But I think it's really quite dangerous. So yeah, to me, it just feels like a ticking time bomb waiting to go off. Okay, I try to be fair-minded about these things, so let me try that again. When a clinician who knows a patient well provides ketamine, compounded ketamine products for the patient to use at home on their own, but the patient is still in ongoing treatment with the clinician, the prescriber, and they're being closely tracked, that's probably okay. And that was an adaptation that we needed during COVID or during the peak of COVID so that people could have access to their ketamine treatment. And I wrote about that, and you can see that. Ava, if you can put that in the chat, that'd be great, the COVID guidelines. This is about how to prescribe lozenges for use at home, and which emphasizes the importance of the clinical supervision of the patient. So the reasons you might do that, in addition to COVID, would be that it decreases the cost of ketamine treatment. That's a good thing. And I like the idea of patients being empowered to have treatment PRN when they need it, rather than having scheduling issues with their clinician. But we have to understand that there are risks associated with ketamine use that's unsupervised. And certainly with mail order programs where there's not close tracking, that's just going to amplify the risks, which include having difficult psychological experience. I have a whole inbox of hundreds of these that have been reported. The patient could be dependent. The ketamine could be diverted. People sometimes experience injuries when they fall down the stairs, or even worse, it's possible that they could hurt somebody else. There have been a number of reported accidental deaths when the person was under the influence of ketamine, both legally and illegally acquired. So we have to have our eyes open and thoughtfully weigh the risks and benefits here. Not to say that it's never appropriate, but it needs to be done judiciously. I can't emphasize that enough. Okay, let me move on in the interest of time. Oh, yes, and also I would be remiss if I didn't talk about this burgeoning, swelling phenomenon of ketamine addiction being reported more and more. I just talked about this a little bit, but it's just essential that we don't turn a blind eye to this possibility. Here's some references for you on this section. Again, you can go back to the reading list for those links. Okay, let me wrap this up and see where we are in time. So here I've now presented for you 3 different approaches to clinical ketamine treatment. So let me recap what I've said already. The first approach that we talked about was emphasizing what happens at a biochemical level and using ketamine as a pharmaceutical. The second approach was focused on psychotherapy and emphasized the psychotherapy relationship and dialogue. The third approach is a psychedelic approach and emphasizes the content of the visions and the psychedelic experience. So all of these are valid, but you have to understand that they're fundamentally different approaches with different assumptions attached to each one. And this makes it more clear when you read the literature, what the researchers or authors talking about, what position they're in. And so the question is, which of these works the best? In other words, as a provider, what should I provide? Or as a patient, what should I seek? And the answer, I have a reference for you. I'll come back to that. The answer to that, obviously, is that different things work well for different people. And in fact, different things work well for different people at different times in the arc of their treatment. And so from my perspective, the competent and the ethical ketamine provider has at least a basic understanding of these different conceptual paradigms and can match the treatment to the patient and can make recommendations that are appropriate to different patients at different times. So it's really, we need to start understanding this as a spectrum of ketamine services with different routes of administration and different dosing strategies, etc. And I think that's how we're going to move the field forward. By the way, I wanted to add that, and I'll just go back for a second, that I actually describe these different paradigms in an article that I published last year. I wrote about using ketamine to treat refractory bipolar depression. But actually, most of what's in that article is broadly applicable to a variety of indications. Ava, can you put that link, the bipolar link, in the chat for me? And so here, this would be a written summary of what I just tried to describe verbally. So let's see. In the interest of time, I think I'm going to fast forward. So we have some established uses for ketamine in psychiatry. I'm not going to talk about that now because I want to make sure we have time for questions. But I'll just show you some slides real quick. Okay. And I want to move towards the home stretch here. I want to say that for patients with depressive disorders, we never prescribe ketamine alone. In fact, I think it's ineffective, but also probably unethical to do that. In fact, the patients who get well and who stay well over time are using a variety of strategies to stay well, including the things on this list. So each patient has a different custom program. And I'm kind of famous for saying that ketamine should never be more than 1/10 of the treatment plan. And I want to point out again that with something like, a nasal spray or a lozenge at home, if none of these other things are being implemented, I don't think that's going to work very well. I think that's going to create addiction and create more problems than it solves. I think that integrative care is critically important. And so here's a map for that. Next thought. Also, back in 2020, we created ethical guidelines for ketamine clinicians. Can we put that in the chat for me, please? This is a very brief document, only a page and a half, that outlines the roles and responsibilities of the medical provider, the psychotherapy or mental health services provider, and the patient. So triangular relationship in ketamine treatment. I just want to point out that this particular document has been cited in multiple inquiries to the board, various boards in different states, and in multiple malpractice suits. And so it's really worth knowing about this particular short document. Please take a look at that. It's quite valuable, and it's meant to be spacious. It's meant to make space for different clinicians to practice in different ways while still being attentive to all of the important safety parameters of ketamine treatment. Please have a look at that. Oh, and I'm delighted to tell you about this. One of the things that's most needed right now in the field of ketamine therapy is getting FDA approval for generic, the ketamine, the cheap kind, for mental health indication. And I have been in a work group. I'm proudly partnered with People Science and Velis Bioscience to tackle this problem. And we have an announcement that's coming very soon. I can't, unfortunately, tell you what it is, but if you would like to be the first to know what's happening, there are two ways to get that information. One of them is that you can keep track of the People Science website. There's the link for you there. Or if you'd like, you can add yourself to the CREA mailing list. There's the link for it there. And so something coming soon to be excited about. Anyway, I want to move over to Q&A. I also want to end my lecture by saying that I do have a website that I've referred to a couple of times. There's all kinds of cool free resources there. There's resources for patients. There's resources for clinicians. I put it there for free for your use. So please enjoy lots of interesting information. And also that's how you can contact me. So with that, thank you for listening to this talk. I would love to take some questions.
Wonderful. All right. Well, thank you so much for that talk, Dr. Bennett. It's an incredibly helpful frame for how to think about this. We do have quite a few questions here in the chat. So kick it off. We have one common theme among a few of the questions is in reference to other psychedelics, how you think about ketamine in the context of other psychedelics. Do you ever think about combining ketamine with other psychedelics? And is ketamine better than other psychedelics? Why is it kind of being spoken about as the optimum drug?
Okay, well, there's a couple different questions in there. Let's take them one at a time. People are currently talking about ketamine because it's in DEA Schedule 3, not DEA Schedule 1. And so it's more available for use when certain clinical criteria are met. There's a lot of confusion about this. It's not, you can't just use it willy-nilly or just because you want to. It has to be clinically indicated. There's a lot of discussion about that. We didn't get to that today, but important question. So a lot of the interest in ketamine is related to its legal status. As I said, that's a conversation for a different day. So that's part of it. Part of it is that ketamine plays well with the medications that are typically used to treat depression or bipolar disorder. So patients don't need to stop typically. They don't need to stop their SSRI medication or their antipsychotic medication in order to get this treatment for depression. So that's an advantage of ketamine that probably isn't true for SSRI, for serotonergic psychedelics. It's very rapid acting, as we discussed. That's another advantage. And it's an incredibly flexible tool that can be used in a variety of ways. And the sessions are relatively short, especially if the dose is lower. So that's a good thing. So those are all the reasons that people are excited about working with ketamine. Also, it's glutamatergic. It's active in the glutamate pathway and does something a little different than the other medications that are available. But it's certainly not good for everyone. I can't wait for the day when all the different medicines, all the different visionary medicines are available so that we can better match the treatment to the patient. Ketamine is complementary with these serotonergic agents like MDMA and psilocybin. And, probably later down the road, a combination like MDMA with ketamine together may be like a super antidepressant for patients with refractory unipolar depression. So certainly some combinations are coming, but because the MDMA or psilocybin are not currently available outside of a research context, it's just harder to study and harder to use. One other thing as I said, ketamine is a glutamatergic medicine. It's a dissociative. And so in that regard, ketamine, particularly in a psychedelic range, it takes you away from who you think you are typically. It takes you away from your story and gives a change in perspective. And I'm pointing, physically up and out for a reason. In contrast to that, the serotonergic agents, things more like MDMA, psilocybin, LSD to some degree, they have more tendency, more capacity to help the patient or the client go down, go toward something in their biographical history, like a knot that they want to untie. And again, I'm categorizing those together as serotonergic agents. So in a sense, what these medicines do are opposite. Ketamine takes you away from who you think you are. These serotonergic agents take you toward who you think you are. And so in a sense, they have opposite psychospiritual effects. So I think there's more to be said about that and more to be studied and understood, but hopefully that gives you a sense of how I think about it.
Yeah, that's incredibly helpful. Thank you. We have another kind of grouping of questions that are curious about learning more about the difference between the ketamine administration alone, like an injection alone, versus an assisted therapy. And I think on a related note, the importance of the dissociative component of ketamine in the experience. There's a question that says, like, what about the studies that show ketamine injections alone and ketamine-assisted psychotherapy have similar outcomes? So maybe commenting on that, and then also the importance of the dissociative component.
Okay. Let me see if I can get my head around that. Thank you for the question. Okay, how am I gonna, let's see here. So let me start here. There is no doubt that ketamine alone does something at a chemical level that helps certain kinds of depression. So for sure, that's a true statement. Ketamine has rapid acting antidepressant properties. But as I pointed out earlier, there's a couple of problems. And the main problem is that the effect is short lasting, it's temporary. And when it wears off, if you haven't given the patient any other skills, the problem is that you just have to keep re-administering ketamine. And that's not good. That's not good for a couple of reasons. Number one, it's potentially expensive. Number two, too much ketamine is linked with damage to the excretory system and bladder damage in particular. So we need to be careful about this as we go forward. So what we want to be doing is I think the ideal way to use this tool is to use the ketamine and pair it with psychotherapy in a lower dose or in a higher dose, depending on the patient's needs. But again, using it to build skills or to resolve issues that has a longer lasting effect. Here's the challenge. The challenge is that we don't at this time have great longitudinal data, or rather we don't have quantitative data to demonstrate this effect yet, although a number of different groups are working on gathering this data. But I don't have it right now to show you. But I also know that thousands of clinicians who are talking to each other in email groups and at conferences, thousands of clinicians who have arrived at the same conclusion separately, they can't be wrong. They're all reporting the same thing, which is that for many patients, using a slightly higher dose of ketamine and or combining it with therapy gives a more durable, longer lasting result. And in fact, some patients, as I said, I've been doing this a long time. Some patients report that they got a tremendous amount of relief from ketamine with therapy. And some patients report that their psychedelic experience was some of the most meaningful experience and most informative experience of their entire lives. So again, this hasn't been fully researched in a formal sense, but again, here's where the information from the field needs to inform the formal research, and then we'll keep going. So anyway, that's part of the question. The other part is the psychedelic experience or dissociative experience. I feel conflicted about this because my philosophy is always to give the least amount of medication that you could possibly give to get the result or effect that you want. I sort of think about this as my prime directive. You know, so, less is good, but sometimes you can't get the effect that you want without going into the dissociative range. And so again, the patients need to be appropriately selected and appropriately prepared for that. And clinicians need to have some training to be able to deal with an altered state of consciousness like that. A lot of things to know. And there is some data that suggests that higher doses of ketamine are more effective and that the results is more durable. And so I put the links up already in my talk, and you can find them again on my reading list. A couple of papers that are suggesting that, and the data is definitely trending there. But again, patient selection and psychospiritual support are critical. Does that answer the question?
Yeah, I think so. And I think just as a slight follow-up, yes, Walter Dunn asked a question about, if with the dissociative component specifically, one might expect S-ketamine to have a more potent effect because it has a higher binding affinity for the NMDA receptor than R-ketamine, and presumably that's a source of dissociative effects. I'm wondering, he's wondering if you have any comment on that.
Sure. Let me take a crack at that. So there's a lot we don't know. Let me start there. But what we know so far is that S-ketamine does appear to have a slightly higher binding affinity for the NMDA receptor, probably by about a third, like 30% better sticking capacity. And here's the thing that's important to know is that, and R-ketamine, the other enantiomer is also doing something. Racemic ketamine, generic ketamine is a mix of these two enantiomers. And racemic ketamine or generic ketamine has both activating and sedating properties. It's both energizing and soothing. So it seems like S-ketamine is more activating and more speedy. And it seems like R-ketamine, this is where the early data is going. It seems like the R-ketamine is more sedating or sleep-inducing or relaxing. So for patients with unipolar organic depression, that's a whole separate conversation, but a more speedy mix like S-ketamine might be a good thing. But I want to say this, for our bipolar patients with refractory depression, refractory depressive episodes, actually the mix of racemic ketamine seems to be a better fit. The activating and soothing properties or the energizing and sedating properties in racemic actually seems to work better for this particular subpopulation. And I wrote about that in my paper. Anyway, there's a lot of different possibilities. We may be able to customize the mix for patients going forward. Some patients may be better suited to S-ketamine, some to R-ketamine, some to the racemic. We may be able to make custom ratios in there. We may be able to add MDMA in or other stimulants. So again, it's a very nuanced area. I hope that's helpful. Also, just to mention, in the new R-ketamine study that just came out, they had an incredibly high placebo response rate, which I think threw off their results in some way. So that's quite interesting. I'd like to dig down into that and understand that better.
All right, thank you. Maybe in the last few minutes, we can address this question, which asks about any cultural differences or differences between countries that have done research on ketamine. Given the context that you mentioned about ketamine just being 10% of the overall treatment plan in an ideal setting, are there differences between different generations of people that get the treatment or cultural differences?
Yeah, thank you for the question. As far as I know, it seems to work around the world. And we're getting data, out of Japan and Korea and some researchers now in Britain and Spain and Sweden and etc. So people are finding the same results no matter where you go. So that's the first thing. So I'm not aware of cultural differences. The main thing that comes to mind is the lack of accessibility. And here in this country, right now this treatment is only available if you can pay out of pocket, at least for the ketamine facilitated psychotherapy. And the FDA approval that we're seeking is going to address this problem. The FDA approval is essential in order to unlock broad medical insurance coverage for this service. And so that's where we're going with that. You also mentioned different generations. So ketamine can be used in older adults for depression. I think that psychosocial interventions are usually better before we add more meds. But because ketamine generally plays well with lots of other medications, it can be used as needed for older adults. You can find a whole section on that on my reading list. Similarly, ketamine can be used for children and adolescents who have severe depressive disorders. Not my favorite thing to medicate people whose brains are still growing, but in severe cases, this is a tool that could be considered. There's been quite a bit written about that. Again, you can find all that on my curated reading list. So as far as I know, it spans all the different age groups. Ketamine for procedural anesthesia is done with babies and little kids, and older adults in the OR. So no reason that you couldn't use this tool for a low-dose psychiatric application in a variety of people.
Wonderful. Well, we've come up to the end of our time. Thank you so much again, Dr. Bennett, for joining us. And thank you everyone for being part of the discussion.